Hello, and welcome to the Academy of Oncologic PTs, Student and New Professional Subcommittees DX Downloads. This month's edition is on cardiotoxicity. It's important to understand the impact of cardiotoxicity, and you might be surprised to know that CVD, or cardiovascular disease, is the second leading cause of morbidity and mortality in cancer survivors after recurrent malignancy. So why does this matter? Well, we know that improvements in long-term survival rates is starting to prompt a shift in the care paradigm from cancer survival to really focusing on cancer survivorship. And this means that there's an increased likelihood that a PT will treat cancer survivors, and it also demonstrates the importance of understanding these long-term consequences of the cancer treatments for the patients that we're treating and how it may impact our role in their care. So, what do we know about exercise training and how it relates to cardiotoxicity? Well, the evidence shows that exercise training is safe and it's feasible across the entire cancer continuum. And we know that it can improve physical functioning and psychosocial outcomes. Specifically, when it relates to exercise training and cardiac dysfunction, the evidence that it may mitigate treatment-induced cardiotoxicity is limited. But that is partially due to the fact that there's just limited investigation into this. However, the available evidence indicates that it's not capable of affecting markers or of subclinical cardiotoxicity. However, a bout of exercise was shown to have positive systemic effects on hemodynamics, musculoskeletal symptoms, mood, and body weight. So that's also quite significant. So who is at the highest risk for cardiotoxicity? According to CPGs for oncologists, there's 3 categories of high-risk treatments that individuals may fall into. Those include the first one being individuals who have had high-dose anthracycline treatment or low-dose anthracycline treatment in combination with lower-dose radiation therapy where the heart is in the treatment field. The second category are those who have been treated with lower-dose anthracyclines or trastuzumab, also known as Herceptin. So they've had those alone, and they also have the presence of any of the following risk factors that are multiple cardiovascular risk, older age, and compromised cardiac function at any time before or during their treatment. Also in the second category is having been treated with lower dose anthracyclines followed by Herceptin, so sequential therapy. And then the last category are individuals who are treated with high-dose radiotherapy where the heart is in the treatment field. And something to note is that the late effects of radiation-related toxicity can manifest a median of 10 to 15 years after exposure. So it's really important to understand the long-term effects of these cancer treatments. So just a little download on what are these different treatments that we're talking about that are high-risk treatments. So anthracyclines, often ending in -icin, are used to treat many cancers, including leukemias, lymphomas, breast, stomach, uterine, ovarian, bladder, and lung cancers. Herceptin is used to treat breast, stomach, and esophageal cancers. And then radiation therapy is another type of treatment. So the other ones were chemotherapies, and radiation therapy is another type of treatment that can improve cancer-related outcomes in a variety of different malignancies. But when the heart may be in the treatment field, it's commonly for the treatment of lymphoma, breast, lung, and head and neck cancers. So what is the physical therapist's role in understanding and treating cardiotoxicity? So we can assess. We can perform risk assessments for cardiotoxicity and cardiac dysfunction, including using our understanding of the high-risk treatments for individuals to understand and categorize who may be more likely to have cardiotoxicity or cardiac dysfunction. We can also screen for cardiovascular dysfunction using our various standardized outcome measures, including those such as a 6-minute or 2-minute walk test, a 2-minute step test, or 30-second sit to stand, just for example. We can intervene when we find cardiovascular dysfunction or ahead of time when we understand that individuals may be at an increased risk for it. So, what we can do is we can support survivors in safely engaging in regular physical activity. And then we can also educate our patients about the importance of physical activity for their long term health and their overall well being. So, what are the main takeaways to understand as it relates to cardiotoxicity and physical therapy? So, the first takeaway is to know that as PTs, we can recognize the signs and symptoms of exercise intolerance and cardiac dysfunction in cancer survivors. And we need to know that the whole spectrum of cancer treatments, not just those that we have mentioned, can cause acute and long term cardiac dysfunction. Therefore, understanding our role in it, and the types of interventions that we can provide is important. So we know that moderate intensity aerobic, resistance, or combined training can significantly improve self-reported physical function in cancer survivors. And what is considered the effective exercise prescription is moderate intensity aerobic, resistance, or combined training that's performed at least 3 times a week. And knowing that supervised exercise appears to be more effective is certainly a case for our role as physical therapists in oncology rehabilitation, and in particular as it relates to cardiotoxicity. If you're interested in learning more, these are our resources that we used for this presentation, and certainly feel free to reach out to us if you have any further questions.